Hello students, welcome to EPG Pathshala. In the present module, we will be studying about dose adjustment in renal and hepatic failure. The contents which we will be discussing are introduction of renal and hepatic function, then we will come to know about failure of renal and hepatic functioning, then we will discuss about the factors affecting renal excretion or renal clearance. We will be discussing about then symptoms of renal and hepatic failure, factors affecting liver function. Then we will see how doses are adjusted based on total body clearance. Then we will see the general approaches of dose adjustment in renal and hepatic disorders. Lastly, we will be discussing about creatinine clearance and its calculation. Then in the last, a list of drug dose adjustment in renal and hepatic failure is also provided. Before we come to know how doses are adjusted in renal and hepatic failure, we should first be knowing about the renal and liver function. So first, in liver function, we know that the term renal refers to the kidney. The kidneys are two bean-shaped organs located near the middle of the back just below the rib cage. Kidneys are composed of different parts including the cortex, medulla, renal papilla and renal pelvis. The figure in this slide shows the structure of kidney. Furthermore, the medulla is subdivided into outer stripe of outer medulla, the inner stripe of inner medulla and the inner medulla. We know that the functional unit of kidney is nephron, the structure that is actually responsible for the filtration of blood and formation of urine. There are 10 lakhs nephron present in each human kidney. Each nephron is composed of initial filtering unit or renal corpuscle and a tubule specialized for reabsorption and secretion. Renal corpuscle consists of glomerulus, Bowman's capsule and various tubules including proximal tubule, loop of Henle, distal convoluted tubule, which can be seen in the figure. So it is important to know or to revise that when blood flows through the kidney, waste products and excess water are removed from the blood and moved to the bladder as urine. The kidneys also regulate blood pressure, balance chemicals like sodium and potassium and make hormones to help bones grow and keep the blood healthy by making new red blood cells. Now next is liver functioning. We know that liver is the largest organ of the body and located in the upper right side of the abdomen below the diaphragm. It is also a gland because it secretes chemicals that are used by other parts of the body. For these reasons, the liver is considered both an organ and a gland. The liver is the reddish-brown, wedge-shaped organ with lobes of unequal size and shape. The liver is connected with two blood vessels including hepatic artery and the portal vein as shown in the figure. Hepatocytes are the chief functional cells of the liver and perform number of metabolic, endocrine and secretory functions. Approximately 80% of the mass of liver is contributed by hepatocytes. The function of these cells are protein synthesis, protein storage, transformation of carbohydrates, synthesis of cholesterol, bile salts and phospholipids, detoxification, modification and excretion of exogenous and endogenous substances, initiation of formation and secretion of bile. So these are the function of liver. Now next important topic is failure of renal and hepatic functioning. What happens in renal and hepatic failure of functioning and what are the possible causes behind that we will look in this section. Firstly, we will be discussing about renal failure. So, chronic kidney disease or CKD is a worldwide public health problem affecting more than 50 million people and more than 1 million of them are receiving kidney replacement therapy. We know that kidney is an important organ in regulating body fluid, electrolyte balance, removal of metabolic waste and drug excretion from the body. So impairment or degeneration of kidney function affects the pharmacokinetics of drug. Some of the more common causes of kidney failure are given in the table as depicted on slide. So we can see that the most common causes which can lead to kidney failure include severe or sudden dehydration, toxic kidney injury, autoimmune kidney disease, acute nephritic syndrome, reduced blood flow, dehydration, hemorrhage, injury, septic shock. These all will lead to reduced blood flow, and furthermore infectious state can also lead to renal failure. Now the causes of renal and hepatic failure. Renal failure can occur due to reduced blood flow, blood clotting in kidney blood vessels and infections. More elaborately when we see, then we come to know that acute tubular necrosis, severe or sudden dehydration, toxic kidney injury, autoimmune disease can lead to renal failure, and reduced blood flow can occur due to low blood pressure, burns, dehydration, hemorrhage, etc. Third was the infection, which can be due to septicemia or acute polynephritis. So, which we have discussed just now were the causes of renal failure. What can be the possible causes of hepatic failure? Possible causes include excess alcohol intake, autoimmune disorder, neoplastic. Viral infections, metabolic instability can also lead to hepatic failure. Disease conditions like hepatitis B, hepatitis C, alcoholic liver, rarely induced liver disease from methotrexate, amiodarone, these can also lead to hepatic failure. Now next topic is factors affecting renal excretion or renal clearance. These factors can be physicochemical properties of the drug, plasma concentration of the drug, distribution and binding characteristics of the drug, urine pH, blood flow to the kidney, biological factors, drug interaction, disease states. In physicochemical properties of the drug, the physicochemical properties include molecular size, pKa and lipid solubility. How this molecular size, pKa and lipid solubility can affect the renal clearance? The molecular size of drug play a very important role in excretion of drugs. The drug with molecular size below 300 Dalton and water soluble are readily excreted by kidney, whereas the drugs in molecular size range below or between 300 to 500 Dalton are excreted both in urine and bile. The pH of urine is dependent upon diet, drug intake and pathophysiology of the patient. So food rich in carbohydrate increases the pH of urine, whereas protein lower it. Urinary excretion of unchanged drug is proportional to the lipophilicity of drug because lipophilic drug is passively reabsorbed to a large extent. Next factor was the plasma concentration of the drug. Plasma drug concentration directly affect the glomerular filtration and reabsorption as both are passive processes. A linear relationship between the rate of excretion and protein binding is shown by the drug which binds to plasma protein. In case of actively reabsorbed drugs, the rate of excretion is negligible until their concentration in the glomerular filtrate exceeds the active reabsorption capacity, for example glucose. In case the drug is actively secreted, the rate of excretion increases with increase in the plasma concentration up to a saturation level. Next factor was distribution and binding characteristics of the drug. Clearance is inversely proportional to apparent volume of distribution of drug. Drugs that are bound to plasma proteins act as a macromolecules and cannot be filtered through the glomerulus. Only unbound or free drug appear in the glomerular filtrate. Next factor was urine pH. The pH of urine is not constant like plasma but varies from 4.5 to 7.5, the two extremes. The pH of urine is dependent on the diet, drug intake and pathophysiology of patient. Food rich in carbohydrate result in higher urinary pH, whereas the food which is rich in protein lowers the pH of urine. Next factor is blood flow to the kidneys. The renal blood flow is important in case of drugs excreted by glomerular filtration and for those that are actively secreted. In the other case, increased perfusion increases the contact of drug with the secretory sites and enhance their elimination. The other factor is biological factor. It includes age, sex, species and strain differences, differences in genetic makeup, circadian rhythm, etc. All these factors alter drug excretion. Renal excretion is approximately 10% lower in females than in males. The renal function of newborns is 30 to 40% less in comparison to adults and maturity between 2.5 to 5 months of age. In old age, glomerular filtration rate is reduced and tubular function is altered. The excretion of drugs is slowed down and half-life is prolonged. Next important factor was the drug interaction. Any drug interaction that alter the protein drug binding characteristics, renal blood flow, active secretin, urine pH and intrinsic clearance and forced diuresis would alter the renal clearance of a drug. The last factor is the disease state which can cause renal impairment. Renal dysfunction greatly affects the elimination of drugs, especially those that are primarily excreted by the kidneys. The main reason of renal dysfunctioning are hypertension, diabetes mellitus, hypovolemia, pyelonephritis, nephroallergens and nephrotoxic agents such as aminoglycosides, heavy metals like lead, mercury, etc. So uremia is characterized by impaired glomerular filtration and accumulation of fluid and protein metabolites that affects the renal clearance of drug. In all these cases, the half-life of drug is increased which may result in drug accumulation and toxicity. Now we will discuss about the factors that will affect the liver function. These factors include alcohol, medication-associated liver injury, obesity, viral hepatitis, hemochromatosis, alpha-1 antitrypsin deficiency, Wilson's disease, mononucleosis and autoimmune hepatitis. So now we will be discussing in details that how these factors affect liver functioning. In alcohol, the excess intake of alcohol causes injury to the liver as a result of alcohol abuse. Acetaldehyde is a toxic chemical produced by the breakdown of alcohol. The alcoholic liver disease occurs after years of heavy drinking, but not all heavy drinkers go on to develop this disease. So, alcoholic liver disease has three forms: fatty liver, alcoholic hepatitis and cirrhosis. Next point is medication associated liver injury. In this, the most common cause is over-the-counter pain reliever acetaminophen consumption. Other pain reliever including aspirin, ibuprofen, naproxen can also cause liver injury. Antibiotics can cause medication-associated liver injury. The antibiotics most frequently implicated in the development of the disease is amoxicillin, clavulanic acid or augmentin. Other antibiotic causing medication-associated liver injury include sulfa agents and isoniazid. Next important factor was the obesity or overweight. As we know that obesity is also among one of the causes of liver dysfunctioning. Then the viral hepatitis. Viral hepatitis causes inflammation of the liver due to a viral affliction. Viral hepatitis is most commonly attributed to the hepatitis A virus, hepatitis B virus, hepatitis C virus. No antiviral therapy is available for the treatment of acute hepatitis A, B and C. As a result, treatment is primarily supportive. Now, hemochromatosis. In hemochromatosis, it is an inherited disorder related to iron metabolism. It is the most common cause of severe iron overload. Excess iron may be deposited into the liver. The abnormal accumulation of iron in the liver causes damage. As a result, levels of liver enzyme begin to elevate, especially AST and ALT. So, the three types of hematochromatosis include hereditary hematochromatosis, secondary and neonatal hematochromatosis. Complication of this disease include cirrhosis and liver cancer. Next factor was the alpha-1 antitrypsin deficiency. It is an inherited disorder that can lead to lung and liver damage. Alpha-1 antitrypsin is a protein that protects the lung. The loss of this protein's protection leads to the destruction of air sacs in the lung, which is termed as emphysema. The liver produces alpha-1 antitrypsin, and if the protein is not the right shape, excess level will accumulate in the liver cells and cause damage. The liver damage leads to elevated liver enzyme, especially ALT and AST. So, alpha-1 antitrypsin deficiency is characterized by the production of little to no alpha-1 antitrypsin in the body. Quitting smoking is imperative to the treatment of emphysema secondary to alpha-1 antitrypsin deficiency. Next was the Wilson's disease. In Wilson's disease, it is a rare inherited disorder of copper metabolism. It is characterized by deposition of excess copper in the liver, brain and eyes and other organs. The excess copper level can cause life-threatening organ damage. After Wilson's disease, next factor was the mononucleosis, which is an infectious disease caused by Epstein-Barr virus. The disease is most common among teenagers and young adults. Last factor was the autoimmune hepatitis. Autoimmune hepatitis is a disease characterized by body's own immune system attacking the liver and causing inflammation of liver or hepatitis. Next is the symptoms of renal and hepatic failure. So first we will discuss about the symptoms of renal failure. The symptoms include reduced amount of urine, swelling of legs, ankles and feet from retention of fluid, shortness of breath due to increased amount of fluid buildup in the body, excessive drowsiness or fatigue, persistent nausea, confusion due to the lack of oxygen carrying blood cells, pain or pressure in legs and chest, then seizures, coma, urinary urgency, nausea and metallic flavor. So these are all the symptoms of renal failure. Next are the symptoms of liver failure. So the symptoms of hepatic failure include nausea, vomiting, right upper quadrant abdominal pain, jaundice due to elevated bilirubin level in the bloodstream, fatigue, weakness and weight loss, swollen abdomen, abdominal tenderness, urine changes, irritated skin, stool changes, loss of appetite, fluid retention and joint pain. The next and the most important topic is adjustment of dose based on total body clearance. So in this, the clearance is the pharmacokinetic measurement of the plasma to clear off a substance per unit time. The unit of measurement is milliliter per minute. The sum of individual clearances by all eliminating organ is called total body clearance or total systemic clearance, or it's sometimes also known as renal clearance or non-renal clearance. Generally, total body clearance will be equal to renal clearance, hepatic clearance and lung clearance. In general, clearance is defined as the hypothetical volume of body fluids containing drug from which the drug is removed or cleared completely in a specific period of time. So, the clearance is described by the equation in which clearance can be calculated by dividing elimination rate by plasma drug concentration. And renal clearance is defined as the volume of blood or plasma which is completely cleared of the unchanged drug by the kidney per unit time. Next factor in the adjustment of dose based on total body clearance is elimination rate constant. Elimination rate constant is the value in pharmacokinetic which is used to describe the rate at which a drug is removed from the system. The equation shown in this slide describes its calculation, where Ct is blood plasma concentration of drug at time, C0 is initial concentration when time is equal to 0, and K is elimination rate constant. Next pharmacokinetic parameter is half-life. Elimination half-life is also known as biological half-life. It is defined as the time taken for the amount of drug in the body as well as plasma concentration to decline by 1/2 or 50% of its initial value. Half-life is related to elimination rate constant by the following equation, in which T half is half-life and Ke is elimination constant. Now next topic is dose adjustment in renal disorder. Both the therapeutic and toxic responses may be altered as a result of changes in drug sensitivity at the receptor site. So the renal function is calculated by the equation in which renal function is equal to creatinine clearance of a patient divided by creatinine clearance of a normal person. So creatinine clearance is equal to rate of creatinine clearance excretion divided by serum creatinine in mg%. So this was the equation which is used to calculate creatinine clearance. The requirement of dose adjustment is necessary with renal impairment, and it can be calculated by the simple formula in which drug dose in renal impairment is equal to normal dose multiplied by renal function. The dosing interval in hours can be computed by another formula in which dosing interval is equal to normal interval in hours divided by renal function. When the drug is eliminated both by renal and non-renal mechanism, the dose to be administered in patient with renal failure is obtained by the formula in which drug dose is equal to normal dose, and in square bracket renal function is multiplied by fraction excreted in urine plus fraction eliminated non-renally. So next was the dose adjustment in hepatic failure or hepatic disorder. The ability of liver to excrete the drug in the bile is expressed by biliary clearance, which is expressed in the equation in which biliary clearance is equal to biliary clearance rate divided by plasma drug concentration. Or this thing can also be calculated when bile flow is multiplied by biliary drug clearance, which is divided by plasma drug concentration. The next slide describes the creatinine clearance and its calculation for children and for adults. Now in the last slides, list of drugs is given whose doses are adjusted in renal and hepatic failure. So in renal failure, we can see that the doses of allopurinol, cotrimazole, colchicine, venlafaxine and amiloride is adjusted. The values before and after renal failure is given in this table. Similarly, the list of drugs whose doses are adjusted in hepatic failure are provided in the current slide. These drugs include chloramphenicol, erythromycin, tetracycline, griseofulvin, metronidazole, anticonvulsant, etc. So students, in the current module, what all we have learned? We have learned about the functioning of renal and liver, that is the functioning of kidney and liver. Then what we have learned, that what happens when the kidney and liver fail to function normally, what are the factors that lead to kidney and liver failure, and the symptoms of renal and hepatic failure. Then we have learned how doses are adjusted in renal and hepatic failure by creatinine clearance calculation, and then we come to know about the drugs whose doses are adjusted in renal and hepatic failure. Thank you.